Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, and welcome to the latest videocast for the Medicine Journal. I'm Albert Ferro. I'm a clinical pharmacologist at King's College London. I'm the chairman of the editorial board for medicine, and I'm delighted to be joined by Dr James Uprichard, who is the editorial board member who covers haematology. So welcome, James.
Thank you, Albert. It's great to be here.
Lovely to see you. And would you like to start off by telling us a bit about what you do, and who you are?
Well, I'm here because Albert's invited me to join the editorial board because I'm a haematologist. And haematology is clearly the most important specialty, perhaps bar clinical pharmacology. But it's important because blood, of course, goes everywhere. And, we as physicians perform lots of diagnostic tests. That's what physicians do. And the majority of our diagnostic tests are performed using blood. Haematology is virtually unique because it combines laboratory diagnostics with clinical medicine. So I have to be a fellow of the Royal College of Pathologists in order to be able to look after the lab, and also a fellow of the Royal College of Physicians to look after patients who have blood diseases. Now, I say that, but actually I'm not really a haematologist myself. I used to be. I do have a CCT in haematology, but nowadays, all I do is look after people who bleed too much, such as patients with haemophilia, people who clot too much, such as patients with thrombosis, and blood transfusion. Nowadays, I can barely spell leukemia, let alone treat lymphoma. Essentially, I'm a perioperative haematologist because surgeons need help when people bleed too much and people clot too much, and they certainly need blood transfusion.
Well, thank you for that overview. I think it's true to say that haematology is a very wide-ranging specialty, and I think you'd agree that haematologists tend to focus on areas of it. Now, obviously, we're appealing to the general physician here, so a lot of what you do and a lot of the specialised areas we won't really need to go into. But we thought it'd be good to talk a bit about things that are of interest and useful for the general physician to know. So we'll touch on a couple of things in this chat here. I would say to the viewers that if you want to find out detail, if you want to read more about anything that we talk about or anything we don't talk about, please do go to the haematology issues, which are April and May 2025. And there you'll find some really good articles which go into great depth into various aspects of haematology for the general physician. So I thought we'd start off with anemia because it's very common. General physicians see it and they need to know a bit about it, how to investigate, how to treat it, and so on. So maybe I could ask you, James, what are the important things that a physician should think about?
So you're right, Albert. Anemia is very common. And essentially, it really means someone whose circulating red blood cell mass is not enough for their physiology, really. So they'll become symptomatic of that. But in terms of, we don't go around looking at that. We look at numbers. And of course, I'm a haematologist. I'm working in a laboratory, so the numbers matter. And currently, the World Health Organization defines anemia as hemoglobin less than 130 gram per litre in a man and 120 gram per litre in a woman. Now, my perioperative bias is that this really should be 130 for everyone. First of all, physiologically, why should women be expected to manage on a lower hemoglobin? That's just nonsense. The other thing is, from a perioperative point of view, let's say in an operation someone loses 500 millilitres of blood during surgery, Well, the woman who has a circulating blood volume of, let's say, 4 litres is going to lose a third more of her hemoglobin mass than the man who has a circulating volume of 5.5 litres, if they lose 500 mils. And of course, what that means is that if you accept a hemoglobin threshold of 120 before theatre, it means that that woman is more likely to need to have a transfusion than the man who loses 500 mils. And of course, transfusions, like everything in medicine, they do good things, but there are risks. They're associated with side effects and complications, and I'd like to avoid those things. In terms of when someone comes in and the full blood count is sent off, and you find that the hemoglobin is low, someone is anemic, there are lots of things that would be useful to look at. And of course, as a hematologist, I can't give away all the secrets, otherwise I'd be out of a job. But from the point of view of a general physician, I think you'd need to look at the whole of the full blood count, because if there's a problem with the white blood cells and the platelets, then this is more likely to be a bone marrow issue, and you'll be squeezing that trigger to get a hematologist involved sooner. We need a blood film. We need to see what's wrong with these blood cells. A reticulocyte count is very useful, because if there is a bone marrow issue, you're going to be reticulocytopenic. Or, of course, if someone has low hematinics, so if you don't have the building blocks, the vitamin B12, the folic acid, and the iron, then you're going to be reticulocytopenic. So as well as looking at those hematinics, we also need to look at renal function, because patients who have renal impairment may not be producing enough erythropoietin. In terms of iron studies, ferritin is the best marker of iron stores. We also need the transferrin saturation. And the reason for that is that transferrin carries, in fact, it transports iron from the bone marrow, from the stores to the bone marrow. Ferritin is an acute phase protein, and therefore it will go up when there's inflammation. And therefore, I always recommend that someone should actually check some kind of other inflammatory markers, for example, a C-reactive protein at the same time. I think once you've sent those sorts of things off, hematinic deficiencies are clearly easily correctable. Erythropoietin may need to be considered, in which case I would get either a renal physician involved if there's renal failure, or a hematologist. If everything draws a blank on that, you certainly need a hematologist to help.
And you mentioned transfusion and blood loss and so forth earlier on. And one of the things that I think people may get a bit confused about is, when should you be transfusing people, and when is it sufficient to just give them those building blocks, to give them iron if they're deficient, or B12 if they're deficient, or whatever? Have you got any guidance around that at all?
Yes, there are actually national, what we call indication codes for blood transfusion. So, and essentially, if your patient doesn't fit into the criteria for any of these indication codes, you shouldn't be transfusing them. And the indications codes are essentially, the biggest one is symptomatic anemia. And that means for most patients, if their hemoglobin is above 70, you don't need to transfuse them. So below 70 and symptomatic of anemia, they need a transfusion. If they're having acute coronary ischemia, then needs to be above 80. Or rather, if it's below 80, you should transfuse them. Mm-hmm. People who have sickle cell anemia and need an exchange transfusion. Now, obviously, that's in the hands of the hematologist. Mm-hmm. People who have recurrent transfusion-dependent anemias, such as thalassemia. Mm-hmm. People who are having radiotherapy due to some complicated radiobiology, which I don't understand. I leave that to clever people. You need to have a hemoglobin above 100 gram per litre for the oxygen-free radicals to work in radiotherapy. And therefore, if it's not correctable by any other means, that is an indication to transfuse. Mm-hmm. And we have massive hemorrhage, i.e., when someone comes in, and I work at St George's Hospital, where we have a major trauma centre, if people come in and they're bleeding to death, you don't wait to ask them if they're symptomatic. You don't wait to find out if their hemoglobin is low. You transfuse them up front in order to save that patient's life. Mm-hmm. So essentially, if your patient doesn't fall into any of those criteria, you really shouldn't be transfusing them. You can do an awful lot with iron. Now, oral iron can take a long time to work, but it can be given intravenously. You can use erythropoietin to help stimulate the bone marrow to produce more red cells. And then in that way, hopefully you can avoid transfusion. Transfusion saves lives, and we should be using it when it's needed. But if we think about the recently published infected blood inquiry that came out last year, as a hemostasis doctor, during my training, we knew that we had wiped out a generation of patients with hemophilia by giving them HIV and hepatitis C infected plasma. And that was the generation of doctors before me had done that. But the received wisdom at the time for me was that we had done our best for the patients and we didn't know about HIV and hepatitis C. It's very clear from the infected blood inquiry that's not quite true. But what it means is that we need to be really thinking that you, whoever it is who's transfusing, who's making the decision to transfuse that patient, and me as clinical lead for haematology, for blood transfusion, may need to stand up in court in 20 years' time. And we need to be able to justify the fact that patient developed HIV, hepatitis C, hepatitis B. Or what about what I call hepatitis W? Of course, hepatitis W has not been discovered yet. But if you think HIV wasn't around, apparently it wasn't around in the 70s, in the early 80s, it clearly was around. We just had not identified it. There's going to be a hepatitis W at some point. So we need to be able to justify, we transfuse that patient to save their life. We transfuse that patient because otherwise the radiotherapy wasn't going to work, etc., etc.
I'll take the point. You can only screen for what you know about and not what you don't know about.
Exactly.
Yeah. Interesting. We'll come back to transfusion maybe in a minute, because one of the things I'm interested in, and you co-authored a chapter on this in the journal, was about patients who refuse transfusion. Maybe I'll just come back to that. But before we leave anemia as such, I just wanted to touch on another common thing which people come across, which is anemia of chronic disease. Do we understand what that is and what causes it and what needs to be done about it, if anything?
We do understand some of it. It is slightly nebulous, but there's essentially, as I say, the anemia of inflammation is really about a functional iron deficiency. So in true iron deficiency, we know that the iron stores are empty. And previously we talked about some of the hematinics and the iron markers that we might request from the laboratory. So the ferritin will be low if the iron stores are empty. In functional iron deficiency, the iron stores are replete, i.e. we've got iron there, but we're unable to mobilize that iron. So we can't take it from the macrophages of the reticular endothelial system to the bone marrow where it's needed to make more red blood cells. So therefore, the ferritin may be normal or even high because of inflammation and being an acute phase protein. But the transferrin, which as we discussed previously, was the transporter molecule for ferrin, transporter for iron, is poorly saturated. So this anemia of inflammation, essentially, when you've got cytokines, inflammatory cytokines, particularly interleukin-6, what it does is it will stimulate the release of hepcidin, a hormone from the liver. And what hepcidin does is it shuts the gate, and the gate being ferroportin, Albert ferroportin. So essentially that gate is for iron absorption, and high levels of hepcidin will shut that gate, and so oral iron cannot be absorbed at all. And sometimes, in those situations, the anemia of chronic disease, if we think it's due to inflammation and hepcidin has shut down ferroportin, often a trial of intravenous iron is worth considering.
So coming back to the point about transfusion and patients who refuse transfusion, how do you manage and navigate that sort of situation?
It's a very good question, Albert. I think it is important to recognize that, of course, blood transfusion is essentially an intervention. All patients should really consent to an intervention. And there are pros and cons, risks and benefits. We've just talked about hepatitis W. So, and patients can certainly have the ethical right to refuse a blood transfusion. Now, at St George's, we've got a population of between 10 and 15,000 Jehovah's Witnesses locally. So we've got quite a lot of experience in managing them, particularly around the time of operations when there's likely to be blood loss and therefore likely to be consideration for blood transfusion. But of course, it's not just the Jehovah's Witnesses who can refuse blood transfusion. Of course, anybody can, and mostly it can be for religious reasons, but also people are concerned about transfusion-transmitted infections. We talked earlier about the infected blood inquiry. Some people just have a thing about not wanting to have someone else's blood. And something that's come up, it's been around quite a while, but it came to the fore during the pandemic about people having blood from vaccinated donors. So essentially, all of these people need to be treated as blood refusers. Now, most of the work that we do in this situation is in the surgical setting. So that's why I have campaigned long and hard and been successful that at St George's, all the patients who are about to undergo surgery at their preoperative assessment, they're asked, one of the questions they're asked up front is there any reason why you might refuse a blood transfusion if your doctors recommend it? At that point, then it triggers the need to have a multidisciplinary meeting with the surgeon and the anaesthetist and the patient and a member of the transfusion team. And essentially, that's because the surgeon needs to decide: am I prepared to operate essentially with one hand tied behind my back if I'm not going to be able to transfuse? Is the anaesthetist happy to put someone to sleep with like that? Now, we would then, part of the workup would be to screen for anemia and any of the causes of anemia, because of course we want to optimize someone beforehand. When we optimize their hemoglobin, we would also want to optimize their blood clotting issues, so ensure that antiplatelet agents, anticoagulants are discontinued to minimize the risk of bleeding. The other thing that I think is quite important is that you need to consider with patients that it's not just will they refuse a blood transfusion when they are bleeding, because people can get so anemic for other reasons, not blood loss, that you might want to transfuse them. And we particularly come across this in the sickle population. Having a sickle crisis, hemoglobin can plummet. And if they're a blood refuser, they're not going to refuse it for life-threatening bleeding. They'll be refusing it for other reasons. They don't want a blood transfusion, and that's fine. We need to be able to work around that. And optimization of patients can include hematinics and erythropoietin, as discussed previously.
Good. So there are ways and means to sort of manage as best you can in those situations.
Yes, I think that's very well put. It is manage as best you can. Do the best for the patient.
Yeah, no, sure. Okay, now you said you're a hemostasis doctor. So one of the other topical things, I guess, at the moment is around the DOACs, the directly acting oral anticoagulants, versus the vitamin K antagonists, warfarin and the like. So what do you think about, has warfarin had its day? Do we still need anticoagulation in clinics?
So first of all, warfarin is a really, really good drug. It works really well. It anticoagulates people. We've got an enormous amount of experience with it. It's been in clinical practice for 70 years or so. It is inexpensive. It costs pennies. It works very well. The trouble is, it's a pain to take. DOACs have essentially been invented, and they have virtually taken over, but not completely. They've been invented to overcome the issues with warfarin. We know that given in fixed doses based on renal function, age, and weight, there's none of this routine monitoring, none of this kind of queuing up for your INR, and INR is 5.5, take 2 milligrams of warfarin, come back in 3 weeks business. And of course, there are fewer drug and drug-food interactions. If you look up in the back of the BNF under interactions, the section on coumarins is as long as my Winnie the Pooh height chart, basically. Warfarin interacts with everything. So from that point of view, you'd think that DOACs could take on warfarin, take over rather. But no, they can't. So first of all the DOACs are to a greater or lesser extent renally excreted. So you have someone in renal failure, that is a problem with the DOAC. And we have given warfarin to these people because warfarin is not renally excreted. Then there are some indications. Arterial thrombosis. Now, in preventing stroke related to atrial fibrillation, the DOACs have enormous amount of phase 3 data about this. They all have licenses for it. But any other type of arterial thrombosis, we need warfarin. People with antiphospholipid syndrome. So certainly, if people are treated for antiphospholipid syndrome, so that's the lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies, then they do better with warfarin. TRAPS trials showed us that. And it may be people who are single positive or dual positive also do better with warfarin, but the trials have not yet come to fruition. Mechanical heart valves. So we've had various trials, starting with the Realign trial, which was with dabigatran. And in fact, the Realign trial was very interesting because it was stopped early because the patients who were taking dabigatran, not only did they get more valve thrombosis from the warfarin arm, so it wasn't working, but they also got more bleeding. So it wasn't as safe. There's the valves, it's probably about, thrombin generation on the valves, actually at concentrations that will overwhelm the DOACs when they're given at their clinically relevant doses. Warfarin, of course, acts, as we know, on 2, 7, 9, and 10 protein C, protein S. So it acts on thrombin and on factor 10. And it's probably this dual action which actually helps in mechanical heart valves. We also know that some other patients were excluded from the DOAC trials, people with atrial fibrillation with moderate and severe mitral stenosis. They probably still need warfarin. In fact, they do need warfarin ideally. And then there's an interesting group of patients. See, if you'd given me the option of warfarin or a DOAC, without the need for routine monitoring, I'd go for a DOAC. But there are some people who really want to know their INR. They want to know that they're in that sweet spot with the INR between 2 and 3. And so they would rather have monitoring. And then there is another thing that thankfully in this country, we don't have this is not an issue for us, but the cost of warfarin tablets is a lot lower than DOACs. And so if you are somewhere where you have to pay for your individual tablets and you don't want to afford a DOAC at £2 a day rather than 5 pence a day for warfarin or something, I think that's another reason to think about warfarin. But so do I think that anticoagulation clinics have had their day? No, I don't.
Well, so I think that's kind of giving a clear message that warfarin does still have its uses. It does still have its indications. So that's good to know. And maybe to finish, James, is there anything new in the haematology world that you think is going to change practice perhaps in the next few years?
Well, of course, everything is new in haematology. It being the most important specialty, everything is important. It's going to change practice everywhere. However, it's a really good question, Albert. I think I'll choose one thing because my bias, as we discussed, hemostasis and thrombosis. And we've always thought of the blood clotting system as essentially a seesaw balance between bleeding and clotting, i.e., if you reduce the risk of clotting, you'll increase the risk of bleeding. Actually, it's not quite true because although they use similar enzyme reactions, if everybody remembers the waterfall hypothesis of blood clotting, those things that I learned from membership and then I use every day, but everyone else forgot, they've got the same enzyme reactions, but they have different effects. So hemostasis is really for stopping bleeding from a vessel injury because it's forming the platelet plug, etc., etc. Whereas thrombosis is blood clotting in the wrong place, an intravascular clot. and that will obstruct blood flow and cause end organ damage. So if we can find something that will uncouple hemostasis and thrombosis, we're kind of onto a winner, I think, now, at least theoretically. So we have some drugs which are in trial, the factor XI inhibitors. And the idea here is that you can anticoagulate someone to prevent thrombosis, but not increase the risk of bleeding. And this has been shown quite well in some phase 2 trials. Dose-dependent reductions in factor XI concentration lead to a reduction in thrombotic complications, but don't correspond with a dose-dependent increase in bleeding. So that's great. And in fact, in some orthopedic surgery trials that have compared factor XI inhibitor with enoxaparin, the low molecular heparin, which is often used as standard, there's certainly non-inferior and some potential superiority. Now, the big money in anticoagulation is not in preventing VTE after orthopedic surgery. That is really important, but actually it's in atrial fibrillation. As we know, atrial fibrillation is a growth industry. 10% of those over 80 have got atrial fibrillation, something like that. And so, in the clinical trials, looking at atrial fibrillation is really important. And there was a trial using one of the new factor XI inhibitors called asundexian. Great names. And there's a phase 2 trial called the Pacific AF trial. And it did look at this, and it showed very well you could reduce the thrombotic endpoints were reduced, and the primary bleeding endpoints were also reduced. Fabulous. So as a kind of phase 2 and therefore effectively as a pilot, they then went on to do a phase 3 trial, which was called Oceanic AF. Now, this was terminated early, again by the Independent Data Monitoring Committee, because there were more thrombotic episodes in the factor XI inhibitor arm, asundexian, than in the apixaban arm, the DOAC. About 1.3% versus 0.4%. Now, there's a big question about why this happened, and they've looked at the data, and it seems that for some reason the incidence of ischemic stroke was much lower than expected in the apixaban arm, and that's probably because of better management of other conditions related to atrial fibrillation. It's also possible that the dose they used of the factor XI inhibitor wasn't enough to suppress factor XI for a full 24 hours before redosing. Because obviously, it'll work for a bit, and then if it tails off, maybe become thrombotic at that time. So the point is, I think for AF, the jury is still out. We still need more trials, but I am hopeful that the factor XI inhibitors may be close to our holy grail in anticoagulation, which is to prevent thrombosis, but not increase the risk of bleeding. We will decouple that seesaw.
Promising avenue, but maybe, as you say, maybe the dose isn't quite right, the drug maybe not quite right, or the population in that particular trial may have been abnormal in some way. So it sounds like an interesting area to keep an eye on in the future.
I think so, yes.
James, thank you very much. I think we've run out of time there. It's been a fascinating conversation. I know we've had a bit of background noise from various bits of work going on around you, but thank you for struggling through that, and great to talk to you.
Lovely to talk to you, Albert. Thank you for your time.